the distinguished colleagues, friends, and honored guests. It's my privilege as president of Korean Liver Transplant Society to welcome you to this session. As we all know, minimally invasive procedures have become the standard of care in many surgical fields because they reduce invasiveness and speed up recovery. In liver transplantation, this means enhanced donor safety, potentially expanded donor pool through better cosmetic outcomes, and ultimately improve the result for both the donors and the recipient. In this talk, I will present a 26 years journey of innovation in liver transplantation. What was once deemed impossible, employing minimally invasive techniques such as laparoscope or robotics for donor procedures, has become a validated and reproducible reality. Today, these methods are further extended to recipient operation, even in the most complex cases. This graph illustrates the history of liver transplantation, my center, Seoul National University Hospital. Our program has marked by several world firsts, from the first laparoscopic-assisted donor hepatectomy in 2007 to the first truly minimally invasive LDLT in 2021. My personal journey began here in 1999 when I joined SNUH as a clinical fellow right at the start of our living donor liver transplant program. I vividly remember those early days, navigating procedures with limited experience and information. However, building up our foundation for progress from the ground. In 2000, at Samsung Medical Center, Seoul, Korea, the primary focus was not on the incision size, but purely on donor safety. All operations were done through a large Mercedes incision. In fact, pioneers like Professor Makuuchi, Japan, even argued that extending the incision to the right chest could enhance safety of donor. Since 2008, as the head of the liver transplantation team at National Cancer Center Korea, the upper midline incision had become the standard for all my donor surgery. When I returned to SNUH in 2010, my senior colleague, Professor Suh, was already pioneering a hybrid approach using laparoscopic mobilization before completing the procedure through a smaller incision. However, at the time, I personally performed all my donor surgery, about 30 to 40% of hospitals total, using only the upper midline incision, because I felt laparoscopic assistance was not truly necessary. The upper midline incision was smaller than the old Mercedes or inverted L incision, but the limited view made the surgery riskier and frankly much more stressful for the surgeons. I dreamed of pure laparoscope surgery, but my early attempts with 2D laparoscope were extremely challenging. I concluded it was not yet appropriate for donors. The turning point came in the autumn of 2015 when our hospital introduced a flexible 3D laparoscopic system. The experience was transformative. The depth perception and precision were so close to open surgery that after about 10 successful cases, I felt confident this was the future. This marked the true beginning of my journey with pure laparoscope donor surgery. My senior Professor Suh performed the first case of our hospital in November 2015. I followed just 1 month later, December 2015. 2015. Yeah, that was the real start of my MIS journey in LDLT. However, my initial series was not without challenges. I encountered several operative events. While they didn't lead to major complications, they were a humbling lesson, reflecting my limited understanding of the specific principles of laparoscope hepatectomy at the time. Another major breakthrough came in March 2016 when our team introduced the ICG fluorescence camera into donor surgery. This technology dramatically improved our ability to visualize bile duct and anatomy, making complex procedures safer and more reliable. The addition of ICG guidance provided both confidence and precision. I was proud to be the first to report the usefulness of this technology for identifying a bile duct anatomy in the literature. Our team then began to share our experience, publishing papers on surgical tips, such as how to manipulate the 3D camera and the principles of optimal port insertion to help facilitate the surgery for others. From the very beginning, we didn't set absolute contraindications. This allowed us to gain experience with cases that other centers might avoid, and we reported several tips to overcome difficulties in donors with anatomical variation. Specifically, I reported my personal series on donors with two right portal veins, demonstrating that the laparoscopic approach could be expanded to these complex cases safely with comparable outcome. We also published data showing that laparoscope donor hepatectomy can be applied safely even in donors who are obese or have a large liver graft. And critically, our research confirmed what we expected. Laparoscope approach provides a superior cosmetic effect, and the laparoscope donors reported the highest wound satisfaction scores compared to all open incision types. We then began to rigorously compare outcomes. And as you can see from these titles, we consistently reported laparoscopic donor hepatectomy showed comparable outcomes to open surgery in various situations. In a propensity-matched analysis of nearly 200 cases in each group, we found that blood loss and hospital stay was significantly lower in lab group. No donors in either group required transfusion. Regarding complications, there were a few minor grade 1 complications in the lab group with no difference in more severe complications. For recipient, there was no significant difference in overall survival or graft survival. However, we did initially observe a higher rate of biliary complications in recipient of laparoscopic graft, which we believe was related with donor warming ischemic time. So when I analyzed my personal series, this was confirmed. Prolonged donor warming ischemic time, not the surgical approach itself, was the significant risk factor for biliary stricture in the recipient. This highlighted the critical need to minimize this donor warming ischemic time, particularly in laparoscopic surgery. As a result, nearly 90% of all donor hepatectomies at our center are now performed laparoscopically. Since 2016, I have personally performed every donor surgery laparoscopically. And following the retirement of Professor Suh in this year, February, our entire team has adopted lab approach exclusively. In March 2017, our center became the first in the world to perform 100 cases of pure lab donor hepatectomy, a kind of major milestone for our program. And just 1 year later, in April 2018, we reached 200 cases, cementing our role as a leading center in the world in this field. My personal learning curve analysis using QSUM showed that I reached a stable plateau in my operation time after 43rd cases. After passing that learning curve, the results speak for themselves. The mean operation time dropped to 180 minutes, and both blood loss and hospital stay were significantly less than the open group and my initial laparoscopic group, all with the acceptable rate of major complications. I have also dedicated much of my career to spreading liver transplantation techniques to other countries. My first international collaboration was with Kazakhstan. Since 2013, I have been leading an educational partnership with 5 transplant centers in Kazakhstan, focusing on developing and strengthening their liver transplantation programs. In Georgia, I have been maintaining a collaboration with Dr. Kova Shanava's team since 2015, supporting the development of their national liver transplantation program. I also started collaboration with Myanmar since 2016. I have also shared minimal invasive donor techniques with several countries. For example, in Kazakhstan at October, we performed 4 donor cases by laparoscope starting from 2016. Recently, I started laparoscopic living donor hepatectomy in Mongolia in February this year. That was the first in Mongolia. With this accumulated experience, we decided to apply the MIS to the next great challenges, recipient surgery. This represents a complexity, completely different level of complexity, with risk of massive bleeding and far greater technical demands. MIRS can be classified into 3 types: small incision, laparoscope-assisted, and totally laparoscope or robot approach. Let me briefly walk you through my experience with this evolution. Let me start with a small incision surgery. During 10 years before starting lap donor hepatectomy, as I told you, I preferentially use upper medullary incision. When you look at the video, there are 6 tips to overcome the limitation associated with a small incision, especially how to safely dissect right liver mobilization is an important tip. Based on this experience in donor, full recipient procedure can be done under upper medullary incision without lap assistance. Under the 16 centimeter incision, all procedures can be done safely in this case. The technique is exactly the same as the recipient surgery under the big incision. However, different from donor surgery, recipient surgery requires anastomosis. Therefore, vascular anastomosis is very difficult under the too small incision, less than 14 centimeter, especially in cases with deep cavity. Therefore, this procedure can be considered in cases with a shallow abdominal cavity and longer incision than donor surgery is required. Next step is laparoscope-assisted recipient surgery. Right liver mobilization is somewhat difficult, so mobilization was done by lap approach, then the other procedures on the upper medullary incision. French group reported their first case of laparoscope-assisted explant hepatectomy, then following graft implantation under the upper medullary incision in DDLT setting in 2020, and the initial series of 6 cases in 2022. I started minimally invasive recipient surgery in June 2020 with 6 cases of laparoscope mobilization, then following surgery on the upper medullary incision. Then the timing of making of midline incision has been delayed step by step up to full separate dissection of each highlight structures for anastomosis. And the first robotic graft implantation was tried in May 21st, but needed open conversion due to bleeding and arrhythmia during portal vein anastomosis. Fortunately, all 10 initial series, including robot trial case, showed favorable outcome. Our team reported the first series of lab-assisted recipient surgery in LDLT. Professor Saw, 5 cases, and my 10 cases were reported. After this experience, our team tried the next level of MIRS, total lab or robot-assisted recipient surgery. Our team, my senior professor, Professor Saw, has prepared the laparoscopic LDLT for several months and then finally succeeded full lab LDLT in April 2021. This is the first success of top-notch MIRS in the world. 2 months later, in June, Professor Saw also succeeded lab explant and hybrid lab robot graft implantation. Robot was applied from hepatic artery and bile duct anastomosis. At the time, I have prepared robot-assisted LDLT for 6 months. And in July, I succeeded the lab recipient hepatectomy followed by robot-assisted graft implantation. Robot was applied for full graft implantation from hepatic vein anastomosis. And finally, I succeeded total robot-assisted recipient surgery in October 2021. Those innovative trials and successes by our team are all the first in the world. Since then, several centers in the world, including Saudi Arabia and Samsung Medical Center Korea, have achieved wonderful progress in these top-notch MIRS. This slide neatly summarizes the evolution of our wounds and the trocar site as we progressed through the different types of minimally invasive recipient surgery in our team. This is my personal series. After our initial cases in 2021, we had a pause, but have now resumed a steady pace since March of this year, performing about 1 robot-assisted recipient surgery per month. As you can see from the first 10 robot cases, there is a remarkable reduction in total surgical time in our more recent operations. This clearly demonstrates our progress past the initial steeping learning curve. But what was truly remarkable is the worm ischemic time. It has been dramatically reduced from 87 minutes in first case, now 45 minutes. The anastomosis time is 71 minutes in the initial case, but now it's 29 minutes. If we break down, you can see that every step of the anastomosis, hepatic vein, the blue color, is now 11 minutes, 9 or 11 minutes, and portal vein, which is blue color is portal vein, orange color is hepatic vein, and artery, red color, and the bile duct anastomosis time, the green color is everything is reduced. This is a brief video from our most recent surgery, illustrate just how smooth and refined this procedure has become. So the male 46, alcoholic liver cirrhosis with HCC. Donor was a wife. Female 41 years old. GRWR was 1.2. There's some adhesion around the liver. First, we isolate the hepatic artery, proper hepatic artery, and encircle, and then clamp. Hepatectomy time takes 263 minutes. Around 4 hours. It's a right hepatic artery and portal vein encircled, bile duct divided, portal vein was clamped, and stapled the middle and left hepatic vein and right hepatic vein, and the finish. There's a non-anastomotic warm ischemic time during put the graft inside and then some repositioning. It takes 16 minutes, and the hepatic vein anastomosis is exactly the same as the open surgery. It takes 13 minutes. And I prepared the total clamping in open surgery, exactly the same as open. I total clamping of IVC without biopump and make a vertical incision on the right anterior wall of right hepatic vein of the recipient. Oh, sorry. So what happened? Okay. Sorry. Something wrong. I don't know. This is portal vein anastomosis. It takes 11 minutes, and then reperfusion. Sorry. And the arterial anastomosis is the aid of proline done by arterial anastomosis done by our colleague Professor Yonglok Choi. As you know, the donor was done by laparoscope. As the aid of proline, continuous suture was done. It takes 20 minutes. And now bile duct anastomosis, Doppler check, and bile duct anastomosis. It's a little difficult for me. Sometimes it takes a long time, but now this is my method. It's like a parachute method: posterior wall, anterior wall, continuous suture, and then pull down. It takes 23 minutes. Okay, I will skip. So the recipient of this is result in early recovery are excellent. The result. Laparoscopic donors are safely discharged on day 5, and similarly, our robotic recipient are demonstrating stable graft function and leaving the hospital as early as day 5 or day 6. But nothing has been more moving for me and my team than these squatting challenges started by our patient. Seeing them successfully perform squats without painkillers just 4 or 5 days after surgery, and then go home the next day. This single image perfectly demonstrates the advantage of this procedure. So I have shared with you the journey from impossible to inevitable. What once seemed like a dream is now an essential and achievable part of modern liver transplantation. I'm very convinced that MIS will become inevitable for both donors and recipients. MIS now becomes golden. I would like to express my deepest gratitude to all the members of the liver transplantation team at Seoul National University, whose dedication and teamwork made all of this this possible. And finally, thank you all. Thank you.